All right, guys. Well, thank you so much for joining me. My name is Priya Vakharia from Retina Vitreous Associates of Florida, and I want to introduce my esteemed guests, Dr. David Chin Yee and Dr. Harit Bhattt.
Thank you so much for the warm welcome, Priya. So happy to be here. I'm David Chin Yee coming from Georgia Retina in Atlanta, Georgia. Looking forward to have a great discussion this evening.
Thanks, Priya. Thanks, David, for having me here. My name is Harit Bhattt. I'm from University Retina and Macula Associates in the Chicagoland area. I've had the pleasure to meet David many, many times, and Priya, it's very nice to meet you as well.
Today, let's talk about geographic atrophy. Geographic atrophy, as everybody knows, is a form of dry age-related macular degeneration where patients get progressive vision loss over time. And I just want to kick it off to Harit. How do you view geographic atrophy now compared to earlier in your career, and what's changing over time with the way that you manage geographic atrophy?
So I think probably like you and David, I'm very much more interested in it again. I think when we first started, or when I first started about 15 years ago, this was kind of, an untreatable kind of endpoint at that point. And now, to me, I look at it as like a chronic disease with some sort of progression that we can modify. We can't necessarily make it better yet, but I think this is a really nice step into the science that starts to modify a disease that's been so debilitating for people for a long time.
So, you said you've been doing this for 15 years. What's changed in the way that you talk to patients now about GA? And did you notice a change in the way that you counseled patients once treatments became available?
Yeah, absolutely. I think, naturally in prior years and, there was nothing really much to do other than counsel, and talk to them about lifestyle modification and then also, low vision utilities, things of that sort. Kind of like we do for our patients who are not necessarily treatment category for what we have now, these therapeutics, and obviously in the last few years, we've seen, we've been lucky to have two FDA approved medications now to counsel patients on, and I think naturally that, brings any conversation you have with the appropriate patient, you can talk to them about these therapeutics now as opposed to just counseling. And, the other thing I'll say is, a lot of times we would maybe see these patients once a year just on a routine thing, or they would come in acutely and if they converted to wet macular degeneration, or they finally kind of snuffed out their fovea and had a loss of vision. And, then you would see them acutely then, but it was really more of an episodic thing. And a lot of times, some of the general eye care providers wouldn't even send them in because there was nothing for us to really do, and now we can kind of be a little bit more proactive and potentially protective for the right patient.
David, we have had treatments that became FDA approved in 2023. And I feel like a lot of us treat GA very differently. There are people out there who are treating the earliest GA, and then there are people who just don't believe in complement therapy. And, I'm just curious, what factors influence your decision about when to initiate treatment? When do you decide that treatment is right for a GA patient?
Yeah, that's a great question. I think, as Harry kind of highlighted, this is a relatively new phenomenon for us. Right before we weren't treating, we look at it as our version of glaucoma. That's how I liken it, actually. Harry, you said in terms of irreversible, progressive, and what we're trying to do is kind of slow down the disease process. It's our version of glaucoma. A lot of our anterior segment doctors understand that. A lot of our patients maybe understand that. So that's the one thing that I think that has changed, is me trying to get the understanding that this is very much like glaucoma. And at least now we have something to slow it down. Before, it's kind of like some of our other neurodegenerative diseases like retinitis pigmentosa, which now we have some treatment. When do I decide to treat? Well, first I need to make the correct diagnosis, right? So there's some things that can look like geographic atrophy. So want to make sure I educate the patient, make the right diagnosis, explain what's going on. And then after identifying it, just like you would with glaucoma, I have that discussion where whether they're early or advanced, I give them the option to let them know you do have this disease process and we do want to consider treatment. Yes, we got to be honest. We all have factors, and Priya, I'm sure you do the same thing. And Harit, you look at the patient. If they are a patient in hospice, maybe that's not the patient I'm going to start treatment on. If it's a patient I've been following, I have a good relationship with them, I can see that there has been significant progression, maybe within the past year, that's also another patient that I may be more inclined to want to treat, right? But quite frankly, I do think it's the patient's choice to determine if they want treatment because we have something available.
I think that's a great question, David. I think that the right patient, and I think this is a paradigm shift, right? And this is was another question that I wanted to bring up, but I also kind of want to talk about. The right patient is not the patient that's symptomatic. And I think that's different for us in retina. We usually wait for patients to be symptomatic. We don't treat 20/20 DME, right? We're not doing that anymore. But I think the right patient to treat, just like you said, is that earlier patient, the one who's maybe not noticing as much symptoms. Again, not that 99-year-old who's just comes in your office and says, "I hope I see you at your next visit." It's the patient that's coming in and you're noticing worsening progressive GA over time. It's extrafoveal. You really want to catch it then to try to preserve as much retinal tissue as possible. Understanding that we still don't have data showing visual benefit, but I still think that preserving retinal tissue is beneficial. Harit, what are your thoughts? Who's the right patient?
Yeah, I think my points are very much echoed by what you guys said. I actually think the most important thing that we do when we're talking about or initiating treatment for this particular disease is patient selection and people who have realistic expectations of what this medication is going to do for them. I'm sure you guys have had this experience where, patients come in after, getting treatment for GA and, they say, "Doctor, I'm not doing any better." And my reply to that is before it used to be kind of a confusing question for me. And now I kind of say, that's the point. That's what we want. This is what I want to hear, and it actually ends up being this reinforcement cycle, So I think when to your point, David, whether it's age or demographics or reliability or compliance, I think we all kind of probably with experience have an understanding of what that perfect patient would be or a good patient would be. That is going to become compliant, that is actually going to show up and, report for duty in some ways to kind of decrease the progression of this disease with consistent therapy. So I agree with everything you both said. I think patient selection is really crucial.
All right, and that was a great segue into our next point, which is talking to patients about GA. So, Harit, you said something about how a patient is coming in to your office and getting treatment and saying, "My vision's not getting any better." How do you deal with these conversations? This is confusing. Patients sometimes aren't sure what medication they're getting. They thought that the wet macular degeneration, the one that you get injections for, but now it's dry, but I thought dry was good, and it's confusing. Because these are really difficult conversations. What tips do you have?
Yeah, I think that's always a challenge we have probably for diseases across, the entire horizon of which we treat, is communicating to the patient what they can expect from our treatments, And I think the first thing I do is really address their concerns. And I know you guys are fantastic physicians and do the same thing, is that I think the quality of the visual acuity that that we get in our history is not necessarily represented in the quantity that we measure in the office, from these patients. So they could have great vision, they could have moderate vision loss, but I think what they're trying to say is that, tell me why this is happening or give me a reason. And that's probably true across the board, but especially for GA when you're injecting someone, they're not necessarily noticing a quote unquote tangible benefit. It's very abstract. And I think the biggest point, at least that I've done, is just continued reinforcement, which, at some point can become arduous and tedious. But if your goal is to probably keep the patient compliant so they do achieve the results or as close as you can in the trials, that's what it takes, and using, FAF imagery and fundus photos and maybe OCT on some occasions, but things that really pop in their minds and their ability to help understand the disorder probably is kind of the best way I've been able to do it.
All great points. David, I'm going to give you a hard situation. You have a patient who you've been treating and they say, this isn't working. I'm not getting better. Mary Jo, my neighbor, is getting better. Her doctor must be giving her a better medication than what you're giving me. I don't understand.
Yeah. Unfortunately, I get that often. Sometimes they come all the way from Chicago. They saw Harit, the neighbor saw Harit and saying, "Hey, David, what's going on here?" All right, so here's the key. Obviously, it's understanding each patient is different, right? First things first, I always tell every patient I see, individualized treatment. I can't speak to, your relative, your friend, but we're focusing on you and what you have and what our objective is. So if I did a good job in the first place explaining the purpose of this treatment, which is the key, Harit said it, I tell him, listen, the way how this works, you're going to lose vision. With what we have today, we're on a train. The train's going to crash. We're going 100 miles per hour with treatment. And what we're trying to do is slow the train down to 80 miles per hour, depending on what you're using, right? The point is slowing down. If our patients, I hate to say this, but if they die, but they maintain their vision, as a retina specialist, we want, right? So, again, it's to highlight that what we're trying to do is to preserve vision as long as possible. And I do tell them this, right? I said, sometimes I look on it and said, oh, we've been on treatment a year and a half, 2 years at this point now. And I said, based on the studies, I can show you where if you were not receiving treatment, you would have already lost central vision. And so, honestly, we don't have a way to tell them, hey, where you were. But similar to some of my mentors that told me back in the day for wet macular degeneration for CNV, they would laser a patient. These patients after treatment would lose vision. And we're telling them, oh, we did something good here. So truthfully, it's kind of revisiting that mantra where we're saying, listen, if you weren't getting this treatment, gosh, I don't know where you'd be. Yeah. And thank our lucky stars, because I do believe we're slowing down the progression and making a difference. So it's, again, using the data set that we have on the natural progression and kind of telling them this is where you'd be. And that's something that I use to clarify to these patients.
Yeah, and I want to pivot here because I'm going to throw out a question that I think a lot of people are probably, I think we have a lot of skeptics in retina, right?
Mm-hmm.
Who say, well, there's never been a visual acuity benefit for any of these drugs. And let's talk about that. What do you guys think? I still believe we're preserving retinal tissue. Mm-hmm. And I think that vision in these trials is difficult. I think that geographic atrophy is complicated. And I think that GA patients don't always use central vision, right? There's a lot of eccentric fixation. We see that on our microperimetry studies. Yep. But what would you say to people out there who say, well, David, you're saying that this is so important that I'm making a difference, I'm making an impact, but there's never been a visual acuity benefit. What do you say to those providers who come and say that to you? Like, what's your answer to that?
Again, we have data where we're preserving vision, right? So in terms of risk, right, some of the newer studies that we have, which I'm sure we may talk about, is looking at, the fact of patients not having loss of vision, right? Meaning letters lost, looking at microperimetry data. So what we're saying is potentially we're saving retinal tissue and preserving vision. No, I'm not improving the visual acuity, but in time, right, in 1 year, 2 year, you would have maintained vision for longer. And I guess that's the kind of selling point that I'm looking at this situation. And give it time, right? The more and more we get patients, longer treatment, we may see that curve as we see in the data set. Mm-hmm. Those curves start to differentiate, and that's where you may start to actually see the impact that you're making. We have data for many different things. And again, the clinical trials, I think we're all a part of studies. You at some breath, you kind of have to give weight that you're doing the best. You're giving these patients, following these patients on a routine basis. I would like to think that the things that we're doing is meaningful and purposeful, and I want to trust the data. And it's up to us to continue pushing that forward, looking on our real world data, looking at our patients. I'm sure we all have examples of patients where we treat one eye, not treat the other. You have patients getting treatment, and you see that it's potentially making a difference. So that's my argument. But I don't like using one-offs, but that's why we have data set. You kind of fall back on the data.
Yeah, and I want to talk about also vision, in these GA patients. Harit, I think we all see those patients who come in, they're 20/20, and they say, I can't see anything. And then you have that patient who's 20/50, and they say, well, I'm doing okay. And it seems there's this weird dichotomy, right, with vision and patient experience. Right. Can you give any insight as to why that is? Why are some patients 20/20 but are having such functional limitations?
That I think it's very hard to define a single patient's quality of vision. And I think that's what we have to really look at here. It's not necessarily quantity of vision and what we measure on, Snellen or ETDRS. I think we're kind of really trying to see is, where are you having difficulty? Is it low light? Is it coming in from, different types of lighting conditions? Is it reading? Is it driving? I think so, reading the Snellen chart or ETDRS charts are probably a simple way for us to check vision, but I think these patients have a much different experience when they're saying, I'm having trouble seeing. I think there's levels and depth to that. Much more individualized than, just kind of checking vision on a chart.
I will expound on that. I mean, we all have patients with either macular puckers, floaters, right? Some patients, it's a 20/20 pucker, and oh my God, they're so miserable. And then you have some that like 20/40, 20/60. I'm like, oh man, you should let me do surgery for this pucker. And they're like, nah, I'm happy. They're 20/40 happy. So, in a patient like that, you do not do surgery on a patient that's happy. Mm-hmm. So again, it is one of those, this tough mindset where you can't just based on 20/20 visual acuity is what the standard should be. And one other thing you mentioned, all of our patients, half of them also have hearing difficulty. And so the complaint I hear a lot is that they're reading the subtitles on the screen, and it's not that they can't read it, but their reading speed is diminished. So by the time they reach the end, it's gone, right? So but guess what? If they take 20, 30 seconds to read the selling chart all the way down the bottom, great. But if they have a time limitation, you best believe they won't be able to do it. So I think these are the other factors that by the time they come to us, we have no idea what it meant for that 20/20 score.
Harit, you have a patient who's getting treated with anti-complement in your clinic. And what do you do to help this patient with their patient experience? What do you do to help them get through your clinic? And how often are you imaging or following these patients while they're on treatment?
We had mentioned prior, I think patient education and reinforcement. So we do use a lot of imaging, as we talked about. And, I will get an OCT pretty much every visit if the patient comes in, not just looking for progression, but also looking for a conversion for macular neovascularization. And then I generally will get fundus autofluorescence and color fundus photography probably every 3 months or so, or 4 months, just to see, not just for patient education, reasons, but also just for myself to kind of track the lesion and things like that. And then, if they've been on treatment for a while, I always like to kind of look back and show them over the course of a year, what's been going on and the level of progression that they may have had over that time. So I think kind of making them part of the experience, and it probably does take a little bit longer than maybe a DME or an AMD patient, a wet AMD patient, to go through that imaging. But I think that in the end, if the goal is to make them part of the treatment and have them stay compliant so we can achieve the best results, these are the things that I've found that happen to work for patients.
I think that's one of the biggest things, trying to optimize that process for patients with geographic atrophy. I think we've done a great job with either wet macular degeneration. Patients come in, get the OCT. They actually can tell me a lot of time, hey, doc, I need a shot, or I don't need a shot, because they either see it or they see it on the OCT. Now we're doing this where, I do get a fundus autofluorescence maybe every 6 months, depending if I think it's rapidly progressing, I may do it earlier. I do an OCT on every visit. Again, same thing like Harit said, to kind of assess if they're converted, because we know this class of medication does have that risk of conversion to wet macular degeneration. But other than that, again, it's kind of going through the imaging, that additional fundus autofluorescence. My technicians and staff kind of complain quite a lot because it's challenging at times, especially if they don't have great fixation, getting consistent, good quality imaging. And so again, you got to be patient with these patients. Make sure you explain to them, this is the reason why we're trying to do it, to be able to show you how things are going on. Blink a lot, use lubricating drops, all these different things. So those are some of the challenges. And then we talk about, unfortunately, none of these medications that we have available are pre-filled. Now, some people don't like the notion of that you have to draw medication up in the vial. Not to mention the fact that these medications are slightly thicker when you draw it up. So again, it's just the process, right? We all have many patients, we're all busy. So yes, it's a little bit challenging, but you may note and keep in mind that this is a part of it. Over time, hopefully, I do think if we could get a pre-filled syringe, that would be fantastic. We will see. But, that's, real world, right? These are the things that want to kind of speed up the process, decrease the risk of infection in terms of having a pre-filled syringe. And then outside of that, then keeping that treatment regimen, depending on the treatment or the medication, the burden is real. These are patients that are potentially getting treated monthly, every other month. On my other disease processes, what am I doing? We're all doing this for the most part. Treat and extend, PRN, depending, some form of extension. With this medication, these treatment options, there's no extension. So keep in mind that burden and that reinforcement, as you said, Harit, is super important. So those are the real world challenges. And I still think understanding that and getting through that process on a continuous basis, we're still learning.
Yeah. And I think, for my patients, the hardest hurdle is the starting of the treatment. I feel like once they're on treatment, we're okay. Once I've gotten them comfortable, once I've gotten used to what to expect, we're okay. And oftentimes then they're reluctant to actually stop therapy. I'll stop therapy in the event that a patient has lost central vision. I'll say there's really no point now if you're 2200, 2400 of continuing this. And I find, actually hesitation. And I think that's so fascinating, right? Because it took so long to get this patient to want therapy. And then I actually find something different. Once they're on therapy, patients really actually feel, and this might be placebo effect, it might be true, it's hard to know, right? But they feel like it's really helping, even if we're noticing that the GA is progressing. So Harit, what do you do? How do you manage patients once they're on treatment, especially when maybe there comes a time that you want to stop treatment and the patient wants to continue? How do you navigate those situations?
Yeah, those are really tough. I think it's very, very hard when someone has lost or getting close to, basically losing fixation, where you start to feel like the risks now are greater than the rewards. It's probably a conversation I've had a few times now that we've, had these medications for a while. I think it all just comes down to the patient. I think some of it is based on what I see and what I see on the OCT. And I still kind of take into account what the qualitative aspects of vision that the patient may have. Do they notice some eccentric vision that we are preserving by treating? Do they notice some sort of stabilization in a scotoma, or they want to keep their ability to read at a certain light condition or low vision? So I think there's a myriad of things that I kind of take into account. It's never just probably my own decision to say, hey, we've got to stop and I don't want to do this anymore. But I do understand your point of when I start to see that the treatment may not be necessarily needed anymore, I start to approach them with these questions to understand kind of what their complaints are about their vision. And, if there is any true benefit of continuing a therapeutic every month or every 2 months, as David said. But it's I think it's individualized pretty much every time,
So Priya, you just said one thing that I think is great is I think it's one of these things where the patients feel that they're fighting. They're actively involved in their care. And so when they're receiving treatment, they already started the treatment. Either they overcome the fear of the needle if they've never had a needle in the eye, the whole concept of it. And so when you feel like you are part of the solution, or you're putting a fight to it, that's why I think they have buy-in and want to continue. So I completely agree with you. I have many patients that that once you start, they're comfortable with continuing. I agree with that. That's a great point.
It's hopeful for them too, right? I think that's the thing, right? They feel some sort of hope, and that in turn kind of reinforces our kind of genuine joy of treating these patients for something that we never could before.
And I want to thank both of you for being here. This was an incredible conversation. And I think I want to close just with one thing that I say a lot and I feel pretty strongly about is that, there are therapies for GA. And I think patients, at least at the very least, deserve to know what they are and deserve to know that treatment options are available. And as both of you said, these are complicated, nuanced discussions. We treat every patient differently, and we could have 10 patients in a day and have 10 different conversations with those GA patients. But there are treatment options, they exist, and at the very least, patients need to know they have GA and validate some of the symptoms that they're having. So I want to thank both of my esteemed panelists for being here today. Harit, thank you so much.
Thanks. Thank you.
And then David, thank you again for being here.
My pleasure. Thank you, guys.
All right,
and look forward to reconnecting hopefully in the future as we have more GA therapies hit the pipeline. Thank you.
Yeah, us as well. Thank you so much.